Hello, and welcome again to the Emergency Medicine Clinics podcast. I'm Patrick Manley, the managing editor for the series here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles centered on a central topic. Today we'll be discussing the recent issue on abdominal and gastrointestinal emergencies. Joining us now are the guest editors for this issue, Drs. Joseph Martinez from the University of Maryland and Autumn Graham from Georgetown University. Dr. Martinez, the first article I would like to look at is Abdominal Vascular Catastrophes by Dr. Singh, Koifman, and yourself. When putting this article together, what were some of the areas you knew you had to cover?
Well, I think one of the things that we were really looking at was those entities that cause abdominal pain that are really time sensitive, and I'm talking about time on the magnitude of minutes to hours as opposed to hours to days or weeks. So we were really looking for things that the clinician needs to be aware of and needs to address as rapidly as possible.
Can you take us through the section on etiology?
Sure. Some of the different entities that we talked about, we start talking about an entity called acute mesenteric ischemia, which is something that most of us have learned about, but oftentimes many of us have not seen it because it's not a tremendously common entity. But one of the sort of key points, I think, is that we are seeing it more and more, and we are diagnosing it more and more. So it's something that really needs to be on our radar screens and something that we're actively looking for. So the other thing that I want people to realize is that when we throw around the term acute mesenteric ischemia, we're really talking about a diverse group of etiologies for that final common pathway. And the etiologies that we think about are arterial emboli, which is the one that most of us think about when we hear about mesenteric ischemia. But you can also develop it from arterial thrombosis or even mesenteric venous thrombosis. And then there's another etiology called non-occlusive mesenteric ischemia, which is sort of a low flow state where blood is being shunted away from the visceral organs to try to continue perfusing other vital organs like the heart and the brain.
I really found the imaging studies section to be particularly well defined. Can you take us through a little of that discussion?
Yeah, of course. This is an area that's really changed dramatically through the years. Oftentimes when we see somebody that has acute abdominal pain and they seem sick, oftentimes people will get plain radiographs looking for free air or signs of perforation. And really in this entity, plain radiographs don't really have a role. And as a matter of fact, it's best if those plain radiographs are normal, because that means that they're probably early in the course of disease before any thing that would have shown up on plain radiographs has developed. Ultrasound has really grown a lot in emergency medicine, so more and more of us are using ultrasound for new etiologies and new disease conditions, but it really doesn't play a role in acute mesenteric ischemia. It's a great screening tool for people that have chronic mesenteric ischemia, so it can be done as an outpatient for those patients. But for patients that come in and you're concerned about acute mesenteric ischemia, it's really not really a test that we would utilize. CT scanning, and specifically multi-detector row CT angiography, has really revolutionized the way that we approach mesenteric ischemia. So in times past, and the approach that many of us have learned and many of us even still practice would be, if we were concerned about this entity, patients would go directly to traditional angiography. But as the technology has really improved with multi-detector row CT angiography, it really is a much quicker and easier screening test to obtain, especially if you're at a place where you don't have 24-hour access to angiography, or the patient comes in the middle of the night and you would need to mobilize a team. Many emergency departments now have the capability of performing CT angiography, and we do so on a daily basis in the chest, looking for things like pulmonary emboli. So it's the same sort of concept, looking at the vasculature in the abdomen.
Any final thoughts on this article?
I think the real important things to think about with mesenteric ischemia is that it's a very, very challenging diagnosis to make, but it's something that you really have to go looking for in patients that have the right risk factors. So the article talks about some historical clues to those different etiologies, and I would urge the reader to kind of look at those and think about those on every patient that presents with acute abdominal pain that may fall into one of these categories, and really ask themselves, could this patient possibly have mesenteric ischemia? And if so, they should really think about trying to nail down that diagnosis, and that may involve doing things that they don't normally do, such as CT angiography. But again, if we don't actively look for this disease process, we're going to miss patients with it.
Next up, I'd like to look at abdominal pain in a geriatric patient by Drs. Luthhauser and McVeigh. Can you take us through some of the key takeaways from this article?
Sure. I think that one of the real key takeaways is something that we sort of intuitively know, which is that elderly patients are not just, sort of the same as every grown adult. They have complex physiology and pathophysiology that really makes the approach to these patients unique. They have a unique set of disease conditions, and the way that they present with those disease conditions is very different than younger cohorts. And the rate of complications, so morbidity and mortality in these patients, is really markedly increased compared to younger patients as well.
Let's take a look at the section on specific abnormalities.
Sure. I think a couple of take-home points on some of those specific abnormalities is worth talking about. So, small bowel obstructions are pretty common in this age group, and even though they present relatively similarly to young people, it's still something that we, as emergency providers, tend to miss quite frequently. And the other sort of concerning feature is that sometimes these patients get admitted to the medicine services as opposed to being appropriately admitted to the surgical services, and clearly when that happens, their morbidity and mortality rises. Some of the other etiologies that are interesting has to do with how much more commonly these disease processes occur in the elderly age group. So things like gallstones, nearly 33% of patients by the age of 70 will have evidence of gallstones. And they present very differently when they have complications from those gallstones. So when you think about a patient with acute cholecystitis, we often think about patients that have some nausea, vomiting, present with acute febrile illnesses and right upper quadrant pain. But more than half of these patients in this age group will have no nausea, vomiting, or fever. And so you can easily be swayed into a more benign mindset for these patients. Things like pancreatitis, it's really astonishing how much different it presents in the elderly. First of all, the elderly have a 200-fold increase in pancreatitis after the age of 65. So that's a tremendous increase in incidence of this disease. And they also have a much higher risk of developing necrotizing pancreatitis, which is a particularly severe form of pancreatitis. So while we often teach that when patients with pancreatitis come in, they don't all need advanced imaging, in this age group, you should really have a low threshold to image them to look for some of the complications of pancreatitis. Similarly, with disease processes like peptic ulcer disease, many of these patients will not have any preceding symptoms of peptic ulcer disease, and they'll just present with a complication of peptic ulcer disease as their first presentation.
I was curious about the appendicitis section, where it's discussed how differently it presents in the elderly versus other age groups. Can you take us through a little of that?
Sure. Appendicitis is one of the most challenging diagnoses to make in this age group because it presents so cryptically compared to younger patients. So the extremes of age, the very young and the very old, are very challenging to diagnose appendicitis in. And appendicitis is an entity that causes a minority. Appendicitis in the elderly is an entity that is rarely seen or not commonly seen, I should say, because it causes about 11% of all cases of appendicitis. But even though it's only 11% of all cases, it causes more than 50% of all deaths. So it's a high stakes sort of disease. And patients in the elderly age group that present with appendicitis often present later in their course, and they often don't have the classic pattern of pain that we think of with young people, where it starts with periumbilical pain and migrates to the right lower quadrant with some nausea, vomiting, and anorexia. So they often present in a very benign fashion, and even their abdominal exam may not be very striking. So any elderly patient that presents with pain, really anywhere in the area that could be possibly appendicitis, you really should have a low threshold to go looking for it. Such a dangerous group of patients when they come in with abdominal pain. The mortality is high just in general. Presenting to an emergency department with abdominal pain and being a geriatric patient, you already have sort of a discernible mortality that's much higher than young people. So as well as some of these patients may appear, I take them all very seriously and urge all of our listeners and readers to do the same thing. And don't be swayed by aspects of the history and physical that point you towards a benign disease process until you've really assured yourself that you've looked for any of the more life-threatening processes.
And any final thoughts on the issue as a whole and how you see these treatments progressing?
I think what our goal when we put this issue together was to really provide some clarity and provide a thoughtful approach to a group of disease processes that we see very commonly. So abdominal pain and GI emergencies in general are one of the most common reasons to see an acute care provider, whether it's an urgent care clinic or an acute visit to a primary care doctor or coming to an emergency department. It's one of the most common reasons why patients present for care. And so trying to have sort of a real thoughtful approach to these patients and a very systematic approach, while also highlighting some of the patient groups that are more vulnerable, such as the immunocompromised patients or patients that have had bariatric surgery, and highlighting some of the real life-threatening entities. That was our goal in putting this issue together.
I'd like to take a quick pause here to let our listeners know they can receive an exclusive discount on this issue by visiting us.elsevierhealth.com/EMC podcast. And now on to you, Dr. Graham. I'd like to start with the article on gastrointestinal bleeding by Drs. Navel and yourself. Can you take us through your thoughts on the areas you hope to tackle for this article?
Sure. I think what we wanted to give clinicians was a nuanced approach to GI bleed. GI bleed treatment is not just about replacing the blood. It's really about assessing the risk of the patient for having a significant bleed that is going to require a significant amount of your resources and time, and then matching that to a treatment plan that is going to maximize the benefit of giving high-risk medications or treatments such as blood, what the value is of giving medications such as Protonix or octreotide, how much does that buy you, and then what to do when things get really bad. How are you going to kind of rescue this patient or stabilize them to get them to the next place?
Let's move on to the area on nasocentric tube aspiration.
Sure. I think by convention, we've been taught that nasogastric aspiration or lavage has a large role in our treatment or assessment of the patient who has a GI bleed. I think, however, the research and the evidence would show that it actually has a very limited and small role in our evaluation of the patient in the emergency department who has a GI bleed. For instance, I think there are other ways to risk stratify patients that has been proven to be more sensitive, more accurate, and less invasive to the patient. When they've looked at all the procedures that we do in the emergency department, NG lavage, or putting an NG tube down, ranks the highest. And that's above dislocation of limbs and then reducing them in the emergency department, central lines, IVs. NG tubes seems to be the most painful for patients. It really gives us very little data in the end. We often miss big GI bleeds that are localized to the upper tract. Even in negative NG tubes, we find that 30% actually have upper GI bleeds. And the only thing that it seems to give us is getting patients to endoscopy sooner, which we can do through other means.
Speaking of endoscopy, let's look at the imaging and endoscopy section.
Sure. I think that endoscopy has both a role of diagnosis and treatment. The timing of it certainly has been a question, and certainly in 24 hours from the time that a patient comes in, it is helpful. Whether or not that time frame needs to be 6 hours, 12 hours, in the next 48 hours, that's certainly debatable. But endoscopy offers us the best way to really diagnose the disease process and then potentially intervene with a treatment. And I think it's the first line screening tool as well as treatment for patients with GI bleed. Other imaging studies, particularly if you're considering lower GI bleed, include radionucleotide tagging as well as interventional radiology, which is able to identify brisk bleeding and really to intervene with treatment such as embolization in certain cases. I think that emergency medicine physicians are very well equipped to take care of the patient with GI bleed. I think one of the things that we can add to our armamentarium is a really good risk stratification, and using tools such as the Glasgow-Blatchford score can be very helpful to our practice, really to improve our cost effectiveness and the speed at which we're able to triage patients with bleeding.
Next, I would like to talk about the article Acute Abdominal Pain in a Bariatric Surgery Patient by Drs. Lewis, Takanaka, and Luber. What do you feel were the main takeaways?
I think the main takeaway was that there are very unique complications that patients with bariatric surgeries and procedures have, and that it's our job as emergency physicians to be well versed in what those are and how to treat them.
Next, I'd like to go through the restrictive procedures section.
Sure. I think the two main restrictive procedures that we see the most are the Roux-en-Y gastric bypass and the sleeve gastrectomy. Now, I would say that if you have a patient who had their procedure about 10 years ago, they probably had a Roux-en-Y gastric bypass. However, more recently, say in the last 5 years, what we're seeing is an uptick in sleeve gastrectomy, which is a much more common procedure today because it has slightly less complications and long-term effects for patients with, it seems, very good outcomes.
Let's look at the surgical complications by procedure.
Sure. I think for these large restrictive procedures, particularly because many of them are done with laparoscopy, you have to be concerned for internal hernia. Internal hernia occurs when there are defects in the mesentery that is caused by the approach used when you're doing laparoscopic surgery, particularly in these two surgeries. What that means is that those defects aren't closed up when the patient is recovering, and it allows bowel loops to migrate through. Unfortunately, it presents like a small bowel obstruction, which we see in a lot of post-surgical patients. But in the case of internal hernias, there's a very high risk of bowel strangulation. So therefore, our typical conservative wait-and-see treatment that we have for most small bowel obstructions due to surgery does not apply to bariatric patients. These patients, you should assume it's an internal hernia until proven otherwise, which requires surgical intervention.
You provide a nice breakdown in Table 1 of the possible complications.
Yes, and they certainly give you a comprehensive view of the type of complications we see with each procedure, as well as an idea of how to approach it from an emergency standpoint. I think that this is a fast-moving topic in emergency medicine, mainly because so many people are having these procedures as a way to modify obesity in this country. We're going to be seeing a lot of patients with these procedures. There will be new complications that we will identify through research and just with time. There are also a variety of new procedures, some of which are laid out in this article, that are coming along. And as patients have these procedures, it's going to be our job to keep up with the types and the treatment of complications related to these bariatric procedures.
Any final thoughts on the issue as a whole you'd like to share?
I think that abdominal pain can be fairly daunting for the emergency clinician, mainly because there are so many differential diagnoses that need to be considered, as well as the life-threatening nature of many of them. I think having a structured way of approaching it can decrease the frustration of the clinician and increase the satisfaction of the patient.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For exclusive discount on the issue we discussed today, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. The CME program is also available. For more information, visit info.theclinics.com. Be sure to follow us on Twitter @eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes. Recent issues of Emergency Medicine Clinics have focused on geriatric emergencies, neurologic emergencies, and severe sepsis care in the emergency department.